What is up, YouTube? Welcome back to the channel. It's Nguyen again. It's my pleasure to welcome you back. If you all have been following my M3 journey and going through all the clerkship rotations, then you already know that I've been doing videos on how to honor and get that outstanding grade on every single one of your rotations. And in today's video, we'll be talking about the OB-GYN rotation, obstetrics and gynecology. Check out all my other rotation videos if you haven't already. If you can't find it, I've already linked the videos up here. I've done videos on internal medicine, neurology, surgery, psychiatry, and family medicine. And so this will be OB, and the last one will be pediatrics, and that'll be rounding out my third year of medical school as I prepare for M4 away rotations and applying into orthopedic surgery. As always, full transparency on how I've been doing my clerkship rotations. O stands for outstanding, which is the equivalent to honors at other medical schools, and it just depends on the grading system that you have. So hopefully the tips I provide in this video, all my other videos on my channel, can really help you get a head start on your rotations and crush your clerkships as well. So like always, we'll be talking about the shelf exam briefly, and then my clinical pearls for how to do well in the clinical rotation and just my advice for that. Of course, that can vary from site to site, med school to med school, and rotation to rotation, but hopefully my experiences can give you all some tips that can help you feel more prepared going into your rotations. So before we get into anything, don't forget to subscribe if you haven't already. I make helpful videos about the field of medicine, clerkships, pre-med, medical students, all of that, so you don't want to miss out. Alright, so let's start by talking about the shelf exam for OB-GYN. As always, you already know what I'm going to say. I'm going to be plugging my Anki videos because I promise you they're really helpful. And my newest video on everything you need to know about Anki in just 15 minutes will get you all set up with Anki from installation all the way to installing the pre-made decks. So I'll link that video up here. Feel free to check it out. And don't forget to check out all my other Anki videos, specifically the video that talks about how to set up Anki for Step 2 in clinical rotations. For all my rotations, I've just been doing UWorld and Anki. So those two things together, UWorld questions with Anki flashcards, have been very helpful, and you're continuing to keep these Anki flashcards going because that's going to be really helpful for you as you get into preparation for Step 2 CK, which will have even more weight these days because Step 1 is now pass-fail. So in regard to the shelf exam, I felt like that was adequate, using Anki flashcards and UWorld to get really good, exposure to what type of questions you'll be asked in your shelf exam. As we go into the clinical side of things now, I'm probably going to break this down into 3 sections. So we're going to talk about labor and delivery, maternal-fetal medicine, and gynecology. So the way my rotation worked, it was 6 weeks and we switched services every week, but for the most part it was like MFM, the maternal-fetal medicine side, which is more clinic and patients on the floors. The gynecology side, which also included gynecology, oncology, which is mostly OR heavy, and then labor and delivery, which was a mix of OR and then just vaginal deliveries. So that was more of the obstetric side to the rotation. So let's start with clinical advice for labor and delivery, the obstetric side of the rotation. So typically I think half of the rotation is obstetrics and the other half is gynecology. So the obstetric side is child delivery, and so most of the time you'll be doing a lot of vaginal deliveries, which are healthy, is what we want for mothers. That's what's recommended if it's possible. And then of course when there's things like breech presentation or a failed vaginal delivery, they're not able to push the baby out, then the other option is C-section, and you'll be doing quite a few of those as well. So we'll start with the vaginal delivery. In regard to what you can do as a medical student, most of the time you're not really doing anything crazy. First time you'll be in the room, they'll usually just have you observe. Maybe you'll do a little bit more like helping hold the mom's legs up in McRoberts maneuver, which is just a position that helps them push the baby out. Other than that, they'll walk you through everything else. As you get more comfortable, they might let you do a hand over hand where you get to help deliver the baby's head. They might let you cut the placenta or deliver the placenta, which is just pulling the placenta out. So in general, you should just know on labor and delivery, there's 3 stages of labor. You have the latent phase of active labor, and then the active phase, that's all stage 1. Stage 2 is when the baby actually passes out through the vagina, and then stage 3 is when you deliver the placenta. And so you'll be reviewing and learning these concepts as you go on, but having that general frame of reference will be really helpful for you. On labor and delivery, a lot of times they may ask you to read a fetal heart tracing. So it's really good to know how to read these fetal heart readings because you get asked that a lot and it can be a great way for you to stand out. And so I've noticed the way that they like to present it is always saying, what's the baseline fetal heart rate? Then you say, what's the variability? So is it minimal variability, moderate variability, or marked variability? Most of the time it's gonna be moderate variability. So if you don't really know, just say moderate. Then you're gonna say if there are accelerations or not, and then if there are decelerations or not. And that's just accelerations in the child's heart rate or decelerations. So accelerations are okay, decelerations are bad. So we'll talk about the decelerations really quickly that you should need to know. So decelerations basically can be early, variable, or late. And there's a mnemonic called VEAL CHOP, and we can just talk about this really quickly. So V stands for variable, and the CHOP part that goes with it means it's cord compression. E is for early decels, and that is the H part of CHOP, and that's due to head compression. So basically, the fetus's head starting to exit the vaginal canal, you can get early decelerations in heart rate. A are accelerations, which stands for O, okay, no problem. L is late, which stands for P, placental insufficiency. Placenta's not delivering adequate nutrients, so that's late decelerations, which are also bad. So basically, early is pretty much fine. The ones you're worried more about are variable and late decels. Now, when you're interpreting a fetal heart rate tracing, a lot of times they may ask you what category it is. There's 3 categories, category 1, 2, or 3. Just remember 3, really bad. 1, pretty much most of the time it's gonna be 1. 2 is everything in between, but most of the time you won't hear a lot of category 2 tracing. So most of the time it'll be baseline between 110 to 160 beats per minute, moderate variability, accels present, no decels, category 1 heart rate tracing. Let's try to do vaginal delivery. Category 3 would be things like it would be sinusoidal, there's no variability, recurrent late decels, recurrent variable decels, and this might sound confusing now, but as you do your training and studying, you'll start to see this more and it'll make a lot more sense to you, but that's just a brief little background on that. Now, if all that doesn't work and you have to do a C-section, whether it's a scheduled C-section or an emergent C-section, here's some tips for being in the OR. If you've already done your surgery rotation, you're already going to be an expert, but I learned actually in my OB rotation that I got to do a lot more in the OR than I even got to do in surgery. Maybe it's because I was more confident now, having done surgery, but also I think because they just tended to trust you more, whereas sometimes the gen surgeons didn't really want med students doing much besides closing lap ports. So I think if you show that you're really, confident in the OR, you know how to be helpful, you know what to do, how to get out of the way, when to suction and when to, dab things down with the laps, you can show that, you're capable of doing more and they might let you do more. So I got to close quite a bit during this rotation, which I really liked since I'm going into surgery. So when you start the C-section, basically some PIMP questions and clinical advice I can give you in the OR would be, first skin incision they do is typically a fan and steel incision. It's a low transverse incision. If you need to go higher up, you can also do something called a Maillard incision that's not really done as routinely. Typically it'll be the fan and steel incision, so they might ask you about that. The fan and steel incision is about 2 to 3 finger breadths above the pubic symphysis, so that's another thing that you can notice and just drop as information that might help you look good and help you get a higher evaluation during the rotation. Basically, the C-section, they'll do the fan and steel incision, they'll dissect till you get to the uterus, and they'll do the uterotomy where they open the incision on the uterus, take the baby out, then you close everything else up. It's a lot more bloody than you might think, but it's pretty simple, pretty easy to follow along. If you have a C-section for breech presentation, something that you might get pimped on is what are the maneuvers to get the baby out. So breech means that the baby's upside down. So head is not down, head is up. So when you're opening up the uterus, the legs are going to come out first. And you should know that you'll do the Pinard maneuver, the love seat maneuver, then the Mauricio Smele Viet maneuver. I think I'm pronouncing that correctly. Something like that. They're all like French names, but definitely look up the maneuvers and kind of know that because the attending might ask you what maneuvers you would do to deliver a breech presentation baby. Honestly, that's all I have for labor and delivery side of things, so let's jump to the gynecology side of things. So on gynecology, you'll be doing a lot of total laparoscopic hysterectomies, which is basically using little ports with cameras to take out the uterus through the vagina. You might be doing total abdominal hysterectomies, which is an open incision. You might also do a fan and steel, open up the abdomen, take the uterus out that way. If there's a lot of fibroids, it's too big to go out vaginally, so you can't do it laparoscopically. There's a lot of reasons you might do an open one, but generally those are the two main surgeries. And then the other ones would be like bilateral salpingio-oophorectomies or bilateral salpingectomies, which are like tubal ligations. So basically all the ones I mentioned just now, besides the total abdominal open hysterectomy, the rest are done through like lap ports. So your role as a medical student, at least at my hospital, would be doing something called manipulating the uterus. Basically, you're sitting between the legs with the device called the manipulator that goes in the uterus, and then it allows you to move the uterus so that they can work and dissect things through the cameras in the laparoscopic ports. So basically, they'll ask you to retrovert the uterus, moving it down, or antevert the uterus, moving it up, and then you can move it side to side. So basically, the best thing you can do as a medical student, it might be hard at first, is to sort of read the surgeon's mind and kind of know what they're going to do. As you do more of these procedures, you basically know the steps they go to, so you can kind of move more to the right side when they're working on that side of the uterus and move to the other side when they start doing the tubes on the other side. You'll follow along, and if you can do that, I think that goes a long way in the OR. Some things that might pimp you on, I think the best thing you can do is review the anatomy. I was not a big fan of reproductive anatomy, but as I saw more surgeries, it was actually a lot more straightforward than I thought. So of course you have like your uterus, fallopian tubes, round ligament, uterosacral ligaments, you have your ovaries, you have your infundibulopelvic ligaments, your ovarian ligaments. So just knowing basically where the main things are and knowing like the key things they might ask you. And so lucky for you, you're watching this video, I'm gonna give you some insider tips. So the infundibulopelvic ligament connects the ovaries to the side wall of the pelvis. It has the blood supply to the ovaries. So that might be something you go for first if you're doing an oophorectomy. You want to cut off the blood supply so it doesn't bleed out. During the hysterectomy, whether it's laparoscopic or open, they'll always be looking to, ligate the uterine arteries. And remember that there's water under the bridge. So the uterine arteries go right above the ureters. So the ureters go right under the uterine arteries. So you don't want to injure the ureters. You always want to locate the ureters on both sides before you proceed with that step. They'll also ligate the round ligaments before usually cutting out the fallopian tubes. And when you're ligating or burning away the round ligaments, an attending once asked me, what is the blood supply that runs through the round ligament? Only one person asked. I didn't know what it was, but now you'll know what it is because I'm going to tell you. It's called Samson's artery. So those are some things you might get pimped on when you're under gynecological service. Alright, so the last part of this video is just going to be general things for like rounding on patients on the floor, and then maternal-fetal medicine, which was just rounding on moms that were, having some type of condition like a placenta previa or gestational hypertension or gestational diabetes or something that were getting admitted. And then also it had clinic involved as well. So in general, for MFM or GYN or OB, if you're presenting a patient, just make sure you have a really good one-liner. So presenting the patient as a 30-year-old woman that's G2, P1, 2, 1, 1, or depending on whatever it is, like that might not actually add up because I just made up those numbers, but present the patient with all the information that you'll hear your other residents presenting with. I think that's really helpful. Post-op patients, just like surgery, check if there's fevers, chills, nausea, vomiting, pain. Are they voiding spontaneously, passing gas, use the bathroom yet? What's their pain scale? Things like that. Now when it comes to just introducing yourself to the patient, always ask if they've had any contractions, any bleeding, any leakage of fluid, and if they can feel the baby moving. Those are usually 4 questions that you can ask. That's really helpful. For MFM specifically, I noticed that there are a lot of patients that come in for gestational hypertension or pre-gestational hypertension, and then pre-gestational or gestational diabetes. Know the difference between the two, how to diagnose them, and how to manage them. A lot of times in the clinics, you're looking at blood pressure logs and glucose logs. So for hypertensive patients, blood pressure logs, you want to make sure they're between like 120 to 130 or under 140, ideally. 140s are mildly elevated blood pressures, I'm talking about systolic, and then 160s are severely elevated. So obviously you want to keep those well controlled. Then you always want to check for people with hypertension is, are they having any headaches? Because the blood pressure gets high, it can affect the blood flow to the brain. Check if they have any right upper quadrant pain, just because the right upper quadrant, if you have a lot of pain there, you're going to concern that maybe they have, HELP syndrome or something like that. So check for right upper quadrant pain, because that's the area where the liver or something might be inflamed. Shortness of breath and blurry vision as well are great questions to ask for patients if they are having hypertension. The only other thing I would add is that you should be ready to ask questions about pre-gestational versus gestational diabetes. And so basically make sure that someone's fasting glucose less than 95 is a goal. 1 hour postprandial should be less than 140. 2 hour postprandial should be less than 120. Test that you can do to test for gestational diabetes would be a 50-gram oral glucose tolerance test. This was basically just a little bit of an overview on some tips and advice for how to crush your OB-GYN rotation. You're going to do labor and delivery, gynecology, and then clinic stuff as well. So hopefully those 3 sections really help you out. Don't forget to check out my videos on Anki so you can crush the shelf exam portion. And thanks for tuning into this video. Don't forget to subscribe and comment with any questions below. Have a great week.